let's, can you see my screen there?
Yes.
Great. Well, good morning. So first of all, thank you very much for asking me to speak to you all. And what I'd like to do today is just share our journey towards an AI-assisted telehealth solution for diabetic eye screening here in this country. Now, I need to declare a couple of affiliations. I'm affiliated to Auckland University. I work for the Health Board, Auckland District Health Board, which is where a lot of this work was done. I'm on the committee which developed the diabetic retinopathy eye screening guidelines for the Ministry of Health here in New Zealand. And I'm also a co-founder of Toku Eyes, who developed the AI that we're going to speak about. Now, there is a Maori proverb, which in English said, "What is the most important thing in the world? The people, the people, the people." And that ethos is really at the centre of what we've been developing here in New Zealand. And I love this quote from Professor Noel Sharkey from Sheffield, who says that decisions about people should be made by people. AI should be considered a tool to assist human decision-making, not its replacement. So that really is central to the whole project that we've developed here in New Zealand and the role of AI within it. Now, before I take you on our journey, I thought it's important just to introduce you to who we are. Now, it's important to say that New Zealand is not Australia. Although we do share very similar flags and we are sitting here at the bottom of the globe, New Zealand sits there bathed in the middle of the South Pacific. Anybody who knows anything about New Zealand may know a couple of things. You may be very familiar with the Lord of the Rings. We obviously play rugby. We have an indigenous people called the Maori people. And we have a Prime Minister, Jacinda Ardern, who is very prominent at the present time. We also share or are blessed with great natural beauty, with lakes and mountains and wonderful seascapes. But that's not New Zealand. So who are New Zealanders? Well, we're a country of about just under 5 million people, and the vast majority of our population is concentrated in one or two urban areas. These urban areas obviously have high infrastructure, quite a developed healthcare system. But as shown by this map here on the right, we are a very rural people too. And actually where the social deprivation is in these rural areas. And these rural areas are, as you can see from our geography, often quite difficult to reach. So we've had this dichotomy in this country. We have urban centres which are well served with good infrastructure and medical services, and we've got a rural, poor, which are difficult and hard to reach and not well served by existing infrastructure and medical services. We are a very diverse group of people. This is an old slide, but it does give you an idea of where we all come from. So as you can see, we come from around the world with populations from Europe, North America, and Asia. As a result, we have great cultural diversity, and this diversity is growing. The predominant population is European, but we have significant ethnic mix from across the board. This is a slide taken from the people groups in Auckland, and as you can see, we're really a microcosm of the world. So sitting down here in our little island, or a set of islands, we are a very diverse group of people. Coming to the core of what we're talking to today, it's no surprise to everybody here that we're in the middle of a global diabetes epidemic. That won't come as news to you. And the problem with diabetes is growing rapidly year on year, with really quite amazing projected outcomes of how many people are going to be living with diabetes over the next decade or so. As you all know, a significant number of patients with diabetes will develop sight-threatening conditions, and it's therefore no surprise that diabetes is the leading cause of blindness in patients of working age. Now that statement, though, is no longer true in the UK. And in the UK, it's actually inherited retinal diseases, which are the leading cause of blindness in adults of working age, not diabetes. And much of this is attributed to screening. The UK has had a systematic screening program for the last 15 years or so, and as a result, they're picking up the changes of diabetic retinopathy early and treating before moderate or severe visual loss occurs. So screening works, but the process of screening is a rather laborious process. Essentially, you have to know who all your patients with diabetes are. You have to then bring them to a facility where you can take a photograph of the back of the eye. That photograph has to be stored, has to be then passed to someone who is able to read it, and that report then has to be passed back to the screening program. Now, in New Zealand, we take 4 images per screening episode, a disc, a macular-centered image on both eyes. And before we started this project, it was taking somewhere around 6 weeks for that report to find its way back to the patient. Also within screening, anybody who does anything with diabetic eye screen will know that the vast majority of patients who we screen have none or minimal disease. So we spend a lot of time looking at normal images. Indeed, only a very small percentage of images actually have significant disease which needs eye clinic review. And there's a small group in the middle who it can be sometimes difficult to tell apart. These are particularly patients with macular disease, because of course, when we're looking at maculopathy, we're looking at surrogate markers of tissue edema. So in New Zealand, in addition to photography, we also have OCT as part of our screening process. And this certainly makes it then much easier for the graders to triage whether the patient has sight-threatening macular edema or whether it's just drusen or macular reflex. Now, New Zealand, although we're a small country of only, as I say, just under 5 million people, our healthcare system is divided into 20 different health boards. Those different health boards have a very different urban-rural mix, and within each one of these health boards, we've got individual screening programs. At one level, that may look as a strength because we've got lots of different programs, but as you can imagine, many of these programs are serving relatively small numbers of people, and they can be reliant on 1 or 2 key individuals. So they can be slightly vulnerable to people leaving or camera systems falling down just because of the scattered nature of the programs we have. There can also be very little consistency sometimes between the reporting standards. So New Zealand has had a program, a diabetic eye screening program for the past 12 years or so. And as I say, we have them established in all our DHBs, but national data suggests that up to 40% of our patients with diabetes in New Zealand are currently not being screened. And of course, this means that patients with diabetes are losing vision unnecessarily, which has both a human and societal cost. And when you look at the problem, you can really see there are 2 main factors here driving this. The first is the human factors. It's difficult to train or get trained personnel to read the photographs, or at least read them economically. The second factor we have is we've got geographic factors. We've got lots of isolated rural communities which are hard to reach and poorly served by existing infrastructure. So our fixed camera systems were not really serving our rural poor terribly well. We also have more roadblocks. This whole process is very bureaucratic, and you need multiple spreadsheets passing images onto graders, graders onto reports, reports back to the central referral hub. So this whole process was slow, laborious, and quite difficult to manage. So for a number of years, we had a vision and said, okay, can we revisit this screening pathway? Can we collapse it? Can we get to a point where we can simply take the images and those images be read on the fly so that we can report back to our patients and get the process moving more rapidly? Can we make it mobile? And essentially, we were looking for these key features. Can we improve our productivity? Namely, can we get a system which would deal with all these normal images quickly? This would leave us with a smaller number of patients with significant disease that we can concentrate our resource on. Can we develop a system which was scalable, which means that we could take it around the country, we could go from 1 center to 10 centers very quickly. A process needs to be fully automated, it needs to be flexible, facilitate OCT, and it has to be acceptable to our patients, to ophthalmology services, and to our funders. And for example, with ophthalmology services, our key problem we have here is that our ophthalmology services, being a public sector service, are overwhelmed already dealing with things like macular degeneration. And the last thing we need is to push a lot of patients from screening into the eye clinic. So we needed to be able to gatekeep appropriately, and we needed to have a solution which wasn't going to overwhelm our tertiary care ophthalmology services. So of course, it will be no surprise to people in the audience to hear that AI is going to have, or starting to have, quite a major impact on ophthalmology. And in many ways, it's surprising it hasn't had more impact just yet because of the power of AI. Now, about 2015, we really started to think seriously about how we could change our model of care. So we had a clear idea of where we wanted to go. The trouble is, we spend a long time not actually having any idea of how we get there. And I'm sure any of you who have been dealing with large projects can have a moment like this when you're wondering how you're going to get from A to B. Fortunately, in Nature Medicine, there's been published a much nicer map than the one we had right at the beginning, which gives an idea of how you get from a concept to actually having a good healthcare sort of machine learning AI sitting within your system. So I'm just going to use this roadmap to sort of illustrate our journey. So we started in 2015 with a problem, and that problem was, could we use an AI-based system to help reform our diabetic eye screening programs? So of course, the next step is to develop a useful solution. When we thought there's no point developing a new solution, can we just use an existing diabetic eye screening AI? Now, at that stage, I knew very little about what AI could do. I knew a lot of the hype, and so I had to spend a little time understanding what AI is. And I think it's just important just to spend a few minutes with you. I appreciate there'll be members of the audience who understand this very well, and there'll be people who perhaps less so. So I'm just going to spend a few minutes just talking about AI. Now, AI is not new. We've lived with it for a long time. And essentially within AI, there are different types of learning. The learning that we are perhaps more familiar with is something called machine learning. Now, with machine learning, what you do is carefully define the features of what it is you want the machine or the computer to identify. So for example, let's take maybe a black t-shirt and a pair of trousers. We can identify the features of the image which makes this a black t-shirt. We can also identify the features of this image which make this a pair of trousers. So then if you give the computer different types of images, it will pick out the black t-shirt and the trousers. The trouble is, if you make the t-shirt blue, or you make the trousers slightly shorter and change some of those features, the machine will no longer be able to recognize what you're looking at. So it will pick out very defined things, but that's not terribly flexible when it comes to processes such as medicine, where there are gray areas. So the part of AI which has really transformed particularly medical services or medical applications is deep learning. And in deep learning, the machine itself learns what the features are within the image that define it as either, for example, a t-shirt or a pair of trousers. What you need, though, is lots and lots and lots of images labeled t-shirts and trousers, and the machine will try and work out eventually what makes this part of an image a t-shirt and what makes it trousers. So then the question is, well, how does a computer learn? Well, the computer scientists who first built these large convolutional neural networks, they use the brain as their inspiration. So of course, within the brain, the core component of the brain are the neurons. The neurons have dendrites, which are collecting information, which they give to the cell body. The cell body integrates those inputs, and there's an outcome as a result. So within a computer network, we have a very similar thing. So we have a node, which is really a mathematical function. That mathematical function has numerous inputs, and depending upon the weighting of those inputs, it produces a certain output. Just like in a brain, these neurons are all connected up together. Within a computer network, these nodes are all connected together as well within different layers, finally giving an output. So the input layer would be the images, for example. The hidden layers would be these various mathematical equations, and the output layer would be, well, is this a t-shirt or is this a pair of trousers? So what I thought I would do is just talk you through how this network learns. For example, let's take this example here of a chicken. So the way the neural network will now start to develop this is it breaks that image down into multiple pixels. And for the sake of this illustration, I've just overlaid a grid. But what it will do is take components of this picture, break it down even further, and start to look at individual pixels one at a time with different filters to try and ascertain what is it about this image which makes this a chicken. So having done that, what it does, it will take this image, you feed the various components of this image, those various pixels into the computer system, and to start with, it will guess. It knows that it's going to be a chicken, but it doesn't know really whether it may be something else like a dog. So to start with, you feed all these bits of information in. The computer guesses it's perhaps not much better than chance, but it learns that, okay, the output should have been a chicken and not a dog. So it goes back through the system and says, okay, what were the relative weightings within those different pixels which made it more likely to be a chicken as opposed to a dog? And basically it does this multiple times until eventually the input balance, or the balance of those various inputs, is such that the outcome is very likely to be a chicken. So there we are. That's summarized a lot of computer science in just a couple of minutes. So having understood briefly what the AI is doing, then we have a question, well, how do we measure the efficacy of a healthcare AI? And the answer is, it's only as good as the data it's trained on. So for those of us clinicians who are not so familiar with judging AI, I would encourage you just to continue to look at it like you would any other medical data. You want to know, okay, what's the original data set? Is that data set sufficiently big such that I can generalize to my patients? For example, in the case of a chicken, if all I did was feed my AI a picture of a red chicken, it will be really good at picking red chickens, but it might not recognize a black chicken. Secondly, is this AI trained on the patients you intend to use it from or tend to use it on? And again, that's very similar to a drug trial. If you're looking at a particular drug, is it going to be applicable to the group of patients that I'm going to use it in? And I would argue, if it's not, should you trust it? An example here, for example, maybe a facial recognition AI. The facial recognition AI, which is trained in Europe, trained on European faces, may be good at recognizing a European face, but it may not do terribly well recognizing an Asian face. Similar and related to that, does the data set have an inherent bias? And it's important to actually be aware of this, because the AI is making associations. So it can make any association, and it may not be making the association that you assume it would do. The example here I'd use is an American military. As you might be surprised, as you wouldn't be surprised to learn, the American military were early adopters of AI. And one of the earliest AIs they did was to say, well, can we recognize a tank in an image? So they had a whole series of images, and at the end of it, they thought they had a pretty good AI which would tell tanks from not being tanks. What they didn't realize is that all the images that contained tanks were darker than the images which didn't contain tanks. The AI, in effect, was not picking out tanks at all. It was just picking out the sort of duller, darker images. So you have to understand the background of the patients that it's being trained on. I think it's also important to ask the question, does it add value to what it is that we're currently doing? I appreciate AI is very glitzy, but at the same point, if it doesn't actually add value to what we are doing in this current system, perhaps it's not the answer to the problem. And as a result of the above, there are ethical considerations. For example, where is the data being stored? Are you using a provider who's going to copy your data? There are issues about data privacy and data sovereignty. So having thought about that, we realized that actually the existing diabetic AIs were not going to be applicable to our patients. Certainly none of the existing AIs are trained on patients from Polynesian or Maori extraction. As a result, the data set will have an inherent bias. The existing AIs would not dovetail very neatly into our existing diabetic eye screening program. And because they had lower sensitivity, they were going to generate a number of false positives and negatives, and that was going to present a problem to us. And finally, we had ethical considerations. Certainly in New Zealand, our system has to be stored locally because of data sovereignty issues. So we come back to our roadmap and quickly ruled out the fact that we couldn't just plug in an existing diabetic eye screening AI into what we were doing. There were also cost considerations. So we then started to think, well, maybe what we need here is a bespoke AI for New Zealand. And as we began to think about this, we realized that we had a very suitable data set because, of course, we've been running diabetic eye screening for over a decade. We had great collaborators within clinics and within academia. And of course, we're working closely with the diabetic eye screening programs, and we therefore had great user engagement. And we thought this will give us an opportunity for developing an AI which would really would dovetail very nicely into the programs we're currently running. So we set up this project, Thea, and the aim of our project really was to develop an accurate diabetic grading AI, which would be operator agnostic. Namely, it didn't matter who took the photographs, that image acquisition process would be fully automated and would identify when an image of sufficient quality was taken, and therefore allow that process to be seamless. We didn't want to be beholden to one camera system. Throughout New Zealand, we have multiple camera systems in use. And the last thing we wanted to do was have to go and buy a whole new set of camera systems. We also wanted to have the flexibility of changing cameras in time depending on our needs. So we decided the system had to be camera agnostic, also grader agnostic. It was not beholden upon one grader to generate all these images. As you can imagine, there are multiple stakeholders in a project like this. So we had to spend quite some time negotiating ethics, and we finally got approval from both national and local bodies to proceed. So we started out with a training set of about 170,000 images from 40,000 individuals. Every one of these images was carefully labeled with their diabetic retinopathy and maculopathy grade. And we use a grading system from 0 to 5 for both retinopathy and maculopathy. So we have a very granular grading system in New Zealand. We also had a validation set of about 60,000 images from another 21,000 individuals. The original data, as I say, with AI, it's always really important just to look at the demographics of the data set you're using. Is it applicable to your data set that you're going to ultimately use the AI in? And not surprisingly, our data set was very representative of patients in New Zealand who have diabetes. It's also heavily weighted to patients with type 2 diabetes because, of course, that's the predominant type. And as with any sort of medical screening service, the vast majority of people are normal, which creates some issues for the AI and some technical issues there that the AI boffins amongst you will be very familiar with. So we ended up with a set of images that was very representative of people with diabetes. So we were now confident that we could proceed. As I said, our retinopathy and maculopathy grading system in New Zealand is very granular, R0 to R5 on the left, and in the right-hand side, maculopathy grading M0 to M5. So we developed our AI, which would grade to the Ministry of Health grading classification. We had to do that for New Zealand, but equally, we felt that was rather complex, particularly for a primary grading system. So we also put alongside it, we collapsed those grades and put alongside it a traffic light system where red was, this is a referable image, amber, this is an image which may need referring, and green, this is an image that does not need referring. I'll just talk you through the design of our AI. It's important to realize that AI is not a single AI. There are really ensembles of AIs to produce these processes. So the first AI we had was an image check AI. So we really had to make sure that the image was of sufficient quality to be read. And that's a really important point, because if you're having to use a human being to grade the quality of the image that you feed into the AI, then you have lost a lot of the utility of the AI, because you need someone to recognize what is a good image. So we had an AI which would recognize what a good image is, that allows the system to proceed seamlessly and automatically. We also had to deal with the fact that we had multiple different cameras. Of course, every camera has different flash, has different color balance, so we had to normalize that image. And then having done all that, we then passed the image to our classifiers, and we had a jury of classifiers, and we were weighing up the jury results before we allocated the image as being healthy, non-referable, or referable disease. So this is an example of patients' images that were deemed to be non-gradable. Of course, every time you take images, patient can blink, so you get a lot of images of eyelids. Patients can have significant disease. And certainly in New Zealand, when we got patients who we're struggling to get images of, we'll often take an anterior segment photograph as to explain why. And of course, in this case, we've got significant cataract. If patients do have significant cataract or lens or media opacity in New Zealand, we do have slit lamps services running alongside. So there'll be a small proportion of patients who, for whatever reason, are not suitably or suitable for screening with photography. But let's assume we've taken a good image. That image, for example, here, this image is then normalized with Gaussian filters, and then we pass that image to the AI. Now, what I've got here by showing the AI map is something called an attention map. And this allows you to see what the AI is making its judgments upon. So as you can see here, the AI is concentrating on all those new vessels at the disc and a few other bits in the periphery. So we are confident that the AI is making the right associations. It's looking at these new vessels and it's using that to decide the grading of this particular image. Now, of course, so far I've been talking about images, but of course, within our system, we have two images per eye. So we've got a macular image and we've got a disc-centered image. So as part of our process of reporting, we have to aggregate the results from both, not just the macular disease and the retinal disease, but also whether it's the macular-centered photograph or the disc-centered photograph. Having got a grade per eye, we then have to aggregate that to a grade per patient, and it's that which is the ultimate outcome for our patients. This just puts that process in a slightly more complex form, and the reason for showing you this is to say that we started off with 22,000 images in this particular simple sample, and of those 22,000 images, only 2,000, either 1%, were excluded because they were not gradable or deemed gradable by the AI. So we were rejecting very, very few images. So having passed through that, what was the results of our application? Now you can describe the results of AI processes in many different ways. No one way will really give you a full flavor of what the AI is doing, but receiver operating curve is one way. As you can see, the receiver operating curve for detecting retinopathy is very, very neat. That for maculopathy, less so, because that's where a lot of our uncertainty when it comes to grading pops in. Certainly when you're looking at patients with young patients, you've got macular reflex, which can look very similar to exudate. You've obviously got a lot of patients with drusen, epiretinal membranes, etc. But to summarize that performance, we ended up with an accuracy of 98%, reasonable specificity, high sensitivity, and most importantly for us, a very high negative predictive value. The negative predictive value was very important because we needed to know that if the machine said the image was non-referable, then we could be very confident that this patient did not have disease which was going to be missed. I've showed you an attention map before, but we can basically generate attention maps for every single patient that we do. And that helps us to look at the AI and say, is the AI looking at what we believe it should be looking at? And here's just an example here. The two on the left are the retinopathy grading AI images, and the one on the right is the maculopathy grading. So we can use these images to explore this so-called black box phenomena. What's the AI doing? Is it making the right associations? Can it therefore be trusted? So here's an example of one of our patients who's gone through, and what the AI does, it reads the retinopathy grade here on the left, it reads the maculopathy grade here on the right, and produces a report. So this is the report that Thea will generate. As you can see, it's producing down on the bottom right-hand corner a traffic light system as to the likelihood of this retinopathy being referable and the maculopathy being referable. And I think we'd all agree that this is an image with referable disease and flagged up red. We can see also here there's lots of information, there's lots of different ways of presenting the results. As I said, we're using a jury system of 5 different AIs to produce that result, and that result therefore produces a probability map of what the results is. And if you look at the probability of the jury, you can see the vast majority of the jury felt that this was R4, which is severe non-proliferative disease, with a reasonably significant probability that this could actually be harboring proliferative diabetic retinopathy. However, as exciting as that is, the real gain of our system are these patients, those who are deemed to be normal. So here we are, the probability of this map is the likelihood that this patient has no retinopathy. Furthermore, they have no maculopathy. Bearing in mind that 70 to 80% of patients going through a screening program have no referable disease, being able to pick up these patients quickly and with confidence really is where the main gain of AI comes into from our perspective. So because we've got a negative predictive value of 99.8%, we can have very high confidence that if a non-referable grade is issued, then that is correct, i.e. we're not going to miss referable disease in our cohort of patients. Of course, there's always grey areas. For example, here's a patient here with suspected macular disease. Is this exudate or is this drusen? So the AI has said there's no significant retinopathy going on here, but there is a possibility that it may have significant maculopathy. Within our system, what that does is prompt the photographer taking the images to take an OCT. Again, the OCT is completely automated, so it doesn't matter who's running that program. They don't have to have the knowledge to know when to take an OCT. The AI prompts them. That then generates OCT, which allows us to then grade appropriately. So as we continue our journey, we end up now, not too far away now, in terms of we have an AI that we put through rigorous evaluation and we felt ready to deploy. So how do we deploy AI within our screening program? So the process is illustrated in this slide. The patient comes along and has a photograph taken. That photograph is stored on the local computer. It's then transferred by a custom user interface into the cloud and the inference read. The inference is then produced back, and within 10 seconds, the person taking the photograph has the results. And of course, those results can then be handed straight back to the patient. In this case, they have no significant disease and on their way out can make their next screening appointment. However, in cases like this, we have significant disease, both for retinopathy and macular disease, and this report is passed to the human grading team. Ideally, that human grading team is also available on the fly, that the AI is linked on the cloud to a reporter around the country, and so around the country would have one retinal physician whose session is to be reporting on the AI images that come through from around the country, and they will then report back to the grader. And again, before the patient leaves their diabetic eye screening appointment, they've already got the results of their grading, and on the way out, they'll make an appointment to the eye clinic. We believe it's very important that you've got a senior, or at least an experienced retinal doctor making these decisions, because it's that person who's going to be the gatekeeper for the eye clinic, and certainly we don't want to be overwhelming our eye clinics. So we had an old system which was taking 6 weeks to find that 5 or 6% of patients who needed to be sent in, and now we have a system which finds that 6% in 10 seconds. So essentially, by integrating an AI system within our diabetic eye screening programs, we've allowed our diabetic eye screening programs to work faster and smarter. And it does that because the AI is providing rapid triage of normals. So it's increasing the productivity and cost effectiveness of the clinician reading the images. Instead of having 20 different clinicians up and down the country gatekeeping all these images, we now have one person, and that one person is doing it for the entire country and is doing it on the spot. So we have a point of care which is consistent around the country. We've also, the AI transforms this fundus camera into a smart diagnostic platform, and we can use any existing camera system. We're not having to go and buy lots of new cameras to facilitate this. Furthermore, we can integrate it into our existing systems in terms of OCT. And what it means is that we can send this camera system anywhere into any of our rural communities, and we don't have to send a trained nurse or photographer to do it because the AI is telling them when they've got an appropriate image to be read. So it really allows us to then push this right out into the communities, which makes it very scalable. So we're at a point where we're ready to start deploying our system, which is really very exciting. So the dream was, or the vision was, to create this unified, automated, scalable system that would allow our diabetic eye screening programs to work smarter and faster, to allow it to be disseminated around the country and to be delivering results very quickly, and at the same time protecting our eye clinics from being overwhelmed with multiple false positives. So as I land this presentation, I think there's just a couple of lessons that I feel are worth sharing about what we've learned on this journey, and there are of course many others, but I think these are the important ones. We had to learn what a good healthcare AI looked like, and we feel it's one that is trained and tested locally. You can therefore rely on it, and it's going to be representative of those who it's intended for. That's really important when it comes to whether this is going to be an acceptable AI solution for our patients. We believe a good healthcare AI is one which is not dependent upon a particular operating system or camera, because otherwise it makes it very inflexible and then you're beholden to that manufacturer forever. I think it's one that has to fully automate the process. The more human involvement you have, the less scalable it is. I think it's really important that you actually understand what's going inside that black box of the AI and that you can interrogate it and understand it for yourself. And it has to be one that respects the data sovereignty laws of the country. It's not a system that's going to be leaking data and sharing it all over the place. I think it's also important that this solution has to solve problems, not create new ones. At the end of the day, the AI there is a tool that's going to assist us. I like to think of AI as a clinical assistant tool rather than being a take over the world, one ring to rule them all tool. It's important to say as well that multidisciplinary collaboration is the key. It's a very exciting thing to be involved with people from lots of different disciplines, and I certainly have enjoyed the journey, but we couldn't have done this without any of the people represented here. And finally, it has to be acceptable to our patients. The last thing we wanted to do was to be on the front news headlines of our local papers with our machine having missed it. So it had to be something that was not going to miss disease, acceptable to our patients, to our funders, and to the clinicians. I think it's important to acknowledge the team. These are just some of the really key people. There's been lots of other people involved. Obviously, we have a clinical team. These are my colleague, Dr. Ole, who's a diabetologist who's been very helpful. My two fellows, Sophie and Moaz, and I have a very large technical team as well, consisting of AI engineers, commercialization experts to help us actually through this journey of developing and gaining the funding to develop this. And of course, my co-founder, Ihsan, as well, who without him, really this journey, we wouldn't have got very far down it. So thank you very much. I hope that was helpful and happy to take any questions.